Hi, everyone, and thank you for joining us for another author interview today, where we're going to be talking with my good friend Larissa Fujii-Lau about our ASGE guideline on the role of endoscopy in the diagnosis of biliary strictures of undetermined etiology. Thank you, Larissa, for being here and for working on this guideline. I know you spent a good 3 or 4 years working on this document. It's a difficult topic to deal with, so thank you for being here.
Thank you, Bashar, and thank you for your patience during those several years.
Yeah, so this kind of biliary strictures, which are suspected to be malignant, but we're not quite sure, is very common in advanced endoscopic practices. I'm sure you deal with several of these cases a week, and we do as well. And it is very important to understand what the evidence shows as far as finding a diagnosis and actually coming up with a diagnosis, because diagnosing these patients early on can ensure that they have the right treatment. And so the guideline that we have focused on 3 clinical questions. So I'm going to ask you about some of these questions, and maybe you can guide us on what the best evidence is and what we recommended for each of these, okay?
Sounds good.
So a patient comes in and to see you, and they have a biliary stricture of undetermined etiology, i.e. you're not sure if this is benign or malignant. And the question is, you do an ERCP, you're successful in cannulating the common bile duct. What should you do next? Should you do brushes alone? Should you do biopsies alone? Or should you do brushes and biopsies? And by biopsies here, we're talking about using a pediatric forceps and getting inside the common bile duct and getting some biopsies. So can you shed some light on what we found and what do you think about this and the recommendation?
Sure. That's a very good question, and that's our first, PICO question. I guess I wanted to first take a step back and because we use kind of different terminology in our paper. We use the term undetermined biliary strictures rather than indeterminate biliary strictures, which is commonly seen in the literature. And we decided to use this term because we included studies in all of our PICO questions that had patients undergoing their initial ERCP. So typically in the literature, indeterminate biliary strictures means that they had a prior non-diagnostic ERCP with brushings. But in our systematic reviews and meta-analyses, we included studies that patients didn't necessarily have to have undergone a prior ERCP with non-diagnostic results. And we thought that was important because exactly what you're saying with this first question is, what should we do even with the initial ERCP? Should we be doing introductional biopsies as well as brushings during the initial ERCP? So going to the first question, as with any of these PICO questions, we also kind of wanted to emphasize that it's very important for you to review the radiology imaging yourself and to have good cross-sectional imaging yourself. I always, when it comes to these indeterminate biliary strictures, particularly non-distal ones, tend to review it with my radiologists to make sure that you know exactly what the plan is going into the first ERCP. So now, going to your question, after you cannulate, we did a systematic review and meta-analysis of 21 studies and found that the incremental yield of the introductal or fluoroscopic guided biopsies with the brush cytology over brush cytology itself was 20%. We also found a lower miss rate of introductal biopsy alone of 41% as compared to a miss rate in the diagnosis of malignancy using brush cytology alone was 58%, as well as sensitivities of brush cytology was significantly lower than introductal biopsies and the combination of introductal biopsies and brush cytology. And so ultimately, with the higher incremental yield, lower miss rate, higher sensitivity, and overall low adverse event rate of the introductal biopsies, we suggested the use of both introductive fluoroscopic guided biopsies with brush cytology for any undetermined biliary stricture in the workup of malignancy. The one thing that we did have a concern about as a panel was that although the overall adverse event rate was low with the introductive biopsies, there were two severe kind of adverse events with the biopsies. One was significant bleeding requiring hospitalization and transfusions, and the other was a perforation requiring surgery. And so due to those concerns, we kind of use the terminology as suggestion, I suggest the use of introductive biopsies. We wanted to emphasize that it's been performed in people that feel comfortable doing these introductive biopsies, because as you know, most of that is freehand, fluoroscopic guided. So, but yes, to summarize everything, the panel and the HGE suggested the use of both introductive biopsies in addition to brush cytology during any ERCP for undetermined biliary strictures.
Very good, Larissa. Thank you for clarifying the undetermined and the indeterminate terminology, which is very important here. So the incremental yield again means, explain to the audience what you mean by incremental yield.
So basically, we looked at patients that had a diagnosis of malignancy with both, with the fluoroscopic guided biopsies as well as the brush cytology. And any of the studies that had the information and direct comparison using these two modalities, we determined how much more malignant diagnoses was captured using the fluoroscopic guided biopsies.
So you were 20% more likely to find a diagnosis or confirm the diagnosis of a malignancy if you use biopsies compared to if you used brushes alone.
So biopsies and brushing compared to brushing alone. Yes.
So if you added, so everybody should get brushings, and then if you added biopsies, then you can increase the yield of detecting cancer by 20%, and you are less likely to miss a cancer by 40-some%, correct?
No, it was a little bit because the miss rate was still pretty high, 41% with the introductive biopsies, but 58% with brush cytology. So yeah.
Very good. Yes, and I know we had a lot of discussion in the panel about being careful. Overall there was, as you reported, one case of perforation, one a case of bleeding, although these are very uncommon adverse events, but they are, definitely the perforation is severe enough. So when doing this, you have to make sure that you have the right equipment, using a pediatric forceps, angle it correctly, make sure you do it under fluoroscopy, and you're not facing a lot of resistance. You want to aim your biopsy forceps like you are aiming to cannulate. And certainly when I do it, and I've done a lot of these, I feel confident with it, but you always have to be careful about not jamming the forceps in there, because you can definitely cause perforation. So that's very good, Larissa, and it's very helpful. And I think in people who have the ability to do that, I certainly in our practice, we do this frequently for these cases because we find that the brush yield, depending on where you are, but we're in a tertiary center, but still the brushing yield cannot, sometimes is inadequate. All right, so very good. So you come in, you do this. Many of us also have cholangioscopes and are able to get in and get bites that way or get biopsies. So the second question we looked at as a panel was, should we be doing cholangioscopy with biopsies? Certainly, a lot of studies discuss that. So what did we find about that, and what's our recommendation?
So this one, was a little bit harder for the panel to make an overall general recommendation, saying that every ERCP with the undetermined biliary stricture. We did come up with specific recommendations in regards to when we would recommend using cholangioscopic guided biopsies. But the overall suggestion is to use cholangioscopic guided biopsies in addition to, the typical ERCP with brushings and intraductal biopsies. But some of the caveats that we had were specifically in patients with non-distal biliary strictures, especially, but the endoscopist has to ensure that they're able to drain the critical liver segments if they are going to do cholangioscopy, particularly in these non-distal biliary strictures, or if somebody had a prior non-diagnostic ERCP, and of course in centers with the experience and expertise with using cholangioscopy, because as we know, you have to have some training in order to recognize the malignancy and where to target your biopsies, as well as to control the cholangioscope. So we got these recommendations because we did, again, another systematic review and meta-analysis, and we found that in 5 of the studies, 4 of them were observational, 1 of them was a randomized control. In the 4 observational studies, the incremental yield of cholangioscopy over ERCP without cholangioscopy was 27%. In the 1 randomized control trial, it was 41%, so even higher. And the sensitivity of the use of ERCPs with the use of cholangioscopy was also higher than that without the use of cholangioscopy. We specifically focused on the non-distal ones because there was 1 study that had a lower sensitivity for cholangioscopy as compared to intraductal biopsies in distal biliary strictures. That wasn't seen in the more proximal biliary strictures. And we, as kind of ERCPs, can tell, when we're dealing with distal biliary strictures, we do have a lot more instability of the cholangioscope. It tends to want to fall out much easier, as well as you can have some difficulty passing the biopsy forceps through the cholangioscope. And so it can make biopsies of the distal, especially the very distal bioduct, difficult. And so that's why we kind of made a caveat of you can definitely consider it in distal, in distal biliary strictures, but particularly in non-distal biliary strictures, these cholangioscopic guided biopsies definitely have a role. Overall, with the higher incremental yield, higher sensitivity, there is no difference in adverse events between the use and not use of cholangioscopy and cholangioscopic biopsies, as well as it was also found to be overall more cost effective, decreasing the amount of procedures required to make a diagnosis. That's why we had recommended suggested the use of cholangioscopic guided biopsies with these undetermined biliary strictures, particularly in those that were not in the distal bioduct.
Yeah, excellent. So, part of the discussion also, Larissa, as you had pointed out, is the reason the panel did not make a blanket recommendation to use this kind of in everybody that has a suspected malignancy is because, this is costly. The equipment is not cheap. It does require training that some providers may not have. And also it is limited by the smaller size of the biopsies that you get from this compared to the pediatric forceps. So those are some of the factors that factored into our making this as a suggestion or a conditional recommendation, and putting some caveats saying, well, if you tried ERCP before with brushes and biopsies and you didn't have it, and it's non-distal, and you have experience, you already have the equipment, then this would be a good option to do it, but otherwise you may or may not use it. Is that accurate?
Yes. And I think I kind of spoke about this in the beginning, but the panel did want to emphasize that you have to make sure that you will be able to adequately drain the proximal ducts after using cholangioscopy, because as we know, you have to instill water or saline inside of there. So, yeah.
Contamination. Yeah, definitely. Okay, excellent. And one of the other questions that we dealt with is a common question. When is a good time to do EUS in these cases? At the time of an ERCP, somebody has a malignant or suspected malignancy, but no obvious, maybe no obvious pancreatic etiology. What is the role of endoscopic ultrasound? There's many of people who many endoscopists who do ERCPs also have EUS, but not all of them training. So what did we find about this, and when is it a good time to do EUS at the time of the ERCP?
So yes, with this, similar to the cholangioscopy question, we did have some kind of caveats in regards to when we would suggest the use of EUS. So the kind of recommendations that we had was in patients that had a prior ERCP that was non-diagnostic, especially those with a distal biliary stricture. And of course, if on cross-sectional imaging, there's other areas that can be targeted, like lymphadenopathy or liver metastasis, then we should suggested the use of endoscopic ultrasound. There was a meta-analysis that showed that the incremental benefit of endoscopic ultrasound, these were in patients that had a non-diagnostic ERCP with this meta-analysis, but it was 15%. The sensitivity of either EUS or ERCP didn't really have any difference, but it was different. It was significantly higher when you combine EUS with ERCP over ERCP or EUS alone. During our subgroup analyses, there's a higher sensitivity in patients with either a distal biliary stricture or pancreatic mass, but we're not really focusing on that group. And there was a lower adverse events with endoscopic ultrasound, so with the incremental benefits, higher sensitivity of the combined US ERCP, lower adverse rate, that's why we suggested the use of endoscopic ultrasound. Particularly an upfront endoscopic ultrasound should be considered in areas where they have the ability to do EUS ERCP in the same session, because that is probably decreases the cost of the cost of the overall procedures. And so this one, some people on the panel do EUSs with every single undetermined biliary stricture. Not everybody in the panel was comfortable saying every patient with undetermined biliary stricture should have an endoscopic ultrasound, particularly if you don't have the ability to do it in the same session. So that's why we kind of gave some recommendations on the caveats of when EUS should be performed in addition to ERCPs.
Yeah, very good. So overall, EUS is helpful in many of these cases, as we have highlighted. We also highlighted that you should not FNA and a suspected hilar malignancy, as this can cause seeding in patients who may be future transplant candidates.
But in those patients, you should be looking for the lymph nodes, and because that could also affect their transplant candidacy. So that's why.
Yeah, the other thing we discussed was that EUS is obviously more a higher resolution compared to cross-sectional imaging at the area of the head of the pancreas. And in practice, we've all seen many cases in which the cross-sectional imaging does not report the finding of a pancreas head mass. And you do detect a small lesion, obviously, on EUS. And one of the benefits of doing that, obviously, if you see a mass by EUS and you FNA it, then you're not having to bring the patient back and finding, undetermined etiology and bushings or negative and things like that. So a careful examination and review of the cross-sectional imaging, like we said, discussing this in multidisciplinary board. Anytime you have a suspected malignancy, this should be a priority. And of course, in any of these interventions that we discussed, you need to make sure that you are well trained and familiar with how to pass the forceps into the common bile duct, how to perform cholangioscopy, how to make sure you drain anything that you injected contrast or you injected saline or water into it, and how to use EUS to your advantage. So we hope that these recommendations from the ASGE will be very helpful for you all. Larissa and the panel worked on this for a very long time, and we detailed all of our systematic reviews, meta-analyses, evidence profiles that we use to come up with these important recommendations. We encourage all of you to read our guideline, and as you know, adherence to guidelines has been shown to improve patients' outcomes. So we hope that you'll find this helpful and that you will use it in your clinical practice. And again, we want to thank the GIE for allowing us to do this auto interview. And once again, thank you, Larissa, on behalf of all of us here in the Standards of Practice Committee. Thank you so much for your work, and we'll see you guys later. Thank you so much.
Thanks, Bashar.